Okay, so welcome to SVIN Break 2020. Due to the current COVID-19 pandemic canceling many vascular and endovascular meetings around the world, the SVIN decided to create an online virtual forum addressing a lot of the pressing issues we all are looking at in the current environment, as well as the months ahead. As a society, we've had many members with pioneering work. One of them is going to speak right now. Just had a publication in Stroke on the very topic. But a lot of the work of our members, honestly, has changed stroke care forever. And I'm glad I can call all of these members close friends. We have a unique role in research, academia, and education. So I'm glad that we have a group of amazing members who volunteered and put in a lot of time and effort. A lot of them are going to be speakers, a lot of them moderating, a lot of them are behind the scenes and don't want their name everywhere. So to provide the best source of education, I am going to be introducing Nguyen from Boston Medical Center. She's an SVIN board member and executive committee member. She has been very active with the society, and she's going to give us the first talk on Primer on Neuro COVID-19, what to know for acute stroke workflow. Just real quick, if you want to ask questions, please click on the Q&A, and I'll be filtering as she's going on, and we'll be discussing the top 10 questions.
Okay, thank you very much, Amir. Can everyone hear me okay? Okay, great. So I'm going to move forward. Thank you very much to Sunil, Amir, for organizing a great webinar for SVIN and also our community at large. The topic today is looking at Primer on Neuro COVID-19 and what you want to know for your acute stroke workflow. I'm going to try to take control. These are my disclosures. And moving along, I wanted to mention that obviously our lives have changed ever since the first case of the coronavirus was described in Wuhan, China. This was the first series published in the Nguyen Journal of Medicine. And this was first called out by one of the physicians from China, Dr. Li Wenliang, who called out this virus and unfortunately was censored and succumbed to the disease later in his course. And many other healthcare workers have also succumbed to coronavirus as a result of being exposed while working. And we commemorate them and we honor them. The coronavirus, we think, has originated from the bat, given the similar genetics. And somehow it jumped, we think, via pangolins and then jumped to the humans. It's a novel disease. And here we are, as of today, we have about more than 3 million cases around the world and deaths of 200,000. If we look at the CNS manifestations or the neurological manifestations of coronavirus, we see that 1/3 of patients will have neurological symptoms. In the central nervous system, this is manifest as dizziness, headache, altered mental status, stroke, ataxia, seizures, and encephalitis in this one case. In the peripheral nervous system, it can manifest as hypoosmia, hypogeusia, and muscle damage. Guillain-Barré has also been reported with SARS-CoV-2 in northern Italy in the series of 5 patients. There were patients who had a prodrome of coronavirus COVID-19 pulmonary illness, and then with the latency of 5 to 10 days, they expressed a Guillain-Barré-like syndrome where they developed lower limb weakness, paresthesias, and rapidly progressed to flaccid tetraparesis. 3 of these patients required mechanical ventilation, but of note, we did not detect the PCR of CSF of coronavirus. If we look at cerebrovascular disease, many of you know about the Wuhan series, where we found that 6% of the 200 patients had strokes, and the patients who had strokes with coronavirus were older. They had typically cardiovascular morbidities, and they also presented with severe pneumonia. And of these 12 patients that had cerebrovascular disease with COVID-19, 5 of them died as of February 29, and so we think this is a negative prognostic factor. Of note, it is important to know that having COVID-19 with cerebrovascular disease doesn't mean that the mechanism of stroke was COVID-19. This is an example of a patient who presented in China with a stroke and also had pulmonary manifestation of COVID-19. Yesterday, you probably heard about the series from Mount Sinai published in the New England Journal of Medicine, where they found a surge of large vessel stroke as a presenting feature of COVID-19 in the young. And this was shared with me by Dr. Joanna Fifi. These patients, young or middle-aged, had pretty significant clot burden in their large arteries and the carotid arteries. And these are the features of the patients that were presented in that correspondence in the New England Journal, of which we see some of them had vascular risk factors. So for this Mount Sinai group, they noticed that there was a credible increase of large vessel occlusion stroke in young patients without major risk factors compared to the usual frequency of large vessel occlusion stroke they had typically noticed prior to this pandemic. We want to acknowledge that the persons in this audience are superheroes. You are clinicians. Many trainees in this audience are vitally important as frontline workers responding to our stroke codes. We do urge you to protect yourselves and to avoid heroic or sacrificial actions that could take you out of the healthcare system, because ultimately you are all a scarce resource. The term protected code stroke was termed first by Dr. Kasravani from the University of Toronto and other colleagues in Canada. And basically, it's the premise of this is that you to think about how you prepare yourself for a code stroke as you get called for an acute stroke patient in the ER. And you want to streamline it such that you have one person dressed up in PPE inside the room with the patient, getting all the information, and another person on the outside with a computer, getting collateral information and trying to get medications ordered and tests ordered as needed. And these two people should be in close contact with each other. If we look at the workflow from the pre-hospital or the emergency room, for every acute stroke patient, in addition to asking the usual stroke symptoms, you now also have to ask for COVID-19 related symptoms, cough, fever, shortness of breath, if they're able to speak. And the one thing that I didn't pay attention to very much when I look at these stroke patients that I do now is I look at their vitals. I look at their SATs. I try to see, are they saturating well, their respiratory rate, and their temperature, because that is an indicator to me if they potentially need an airway, if I have to do a procedure or intervention on them. All these patients should wear a surgical mask walking in, because you need to assume that they may have COVID, and you also need to protect the patient. And if the patient is a positive screen, if you have a negative pressure room, that patient should be placed in isolation. And if the patient needs oxygen, you can give them nasal cannula, but put the surgical mask over the nasal cannula. If you have the luxury of telehealth, please use it. And again, you want to minimize the number of providers who care for the patient so that you have less people exposed. The issue of masks is quite important. If we look at the countries where the coronavirus deaths were well controlled from the get-go, these were the countries that utilized masks very early on, having had experience with the SARS in 2003. Whereas the countries, the Western countries that hadn't had as much exposure to the SARS experience, didn't have masks early on and have higher rates of COVID-related deaths, and some of them going off the charts. The Hong Kong scientists looked at the efficacy of facial surgical masks when confronted with a series of patients who had respiratory-related symptoms from influenza rhinovirus or influenza virus. And so they had patients wear a mask or wear no mask, and then they had them collect some exhaled samples to see what was the proportion of samples that had these particles of virus. And so basically what we're showing here is that people who had a mask had much less expression of these viral PCRs than people with no mask. So it is a potential area of protection. This is a nod for the Star Wars fans in the audience that talks about the mask with Darth Vader. When we look at physician changes, there are several things to change in our own workflow. Right now, I keep wipes and gloves in my car. I've dropped the white coat and my tie a long time ago. Scrubs, if available, should be utilized by all persons. And then my phone, I place it in a plastic bag so that when I transition in and out of the hospital, I can easily just slip it out and not have to wipe it again. I've dropped the reflex hammer, the stethoscope. For people who wear contact lenses, you may consider changing to eyeglasses. This has been recommended by the American Academy of Ophthalmology. For men, consider shaving, and women, tie your hair back. In the code stroke, new challenges we face are such that patients who come in with a facial mask, this in itself can mask the detection of facial weakness or a neurological exam, and that could potentially delay detection for the acute stroke patient. The face mask can have a wire, and then if you have to go to MRI, you have to think about the logistics. What do you do about this mask in an MRI? We've reorganized our stroke units to prioritize COVID-19 units, such that instead of a patient going to a stroke unit, you would prioritize them going to a COVID-19 unit if they were positive, because you don't want that COVID-19 patient to go into a stroke unit and then potentially infect the whole stroke unit. This has already been written about from the Chinese literature. And then we've also read from Neurology Today and in Continuum of neurologists who have been redeployed to treat COVID-19 in New York City, Spain, and also in Boston. PPE is a scarce resource, and so we have already engaged in recycling our N95 masks. We have a plant out in Somerville, not too far from Boston, where we have these masks exposed to vaporized hydrogen peroxide. And the way this works is that we think it breaks down the membranes of the virus and the bacteria and sterilizes the N95 for reuse. The caveat with these N95 masks is that you don't want to wear any makeup nor aftershave, because that can render the mask usable. This is some improvisation for healthcare workers who didn't have appropriate PPE because of the lack thereof. And so you see here is a ER doctor in New York with a ski goggle. And then one of the ER doctors in my own hospital has a mask that was made by her husband. And then if you really want to get creative, you can go to your local stationery store and get a protective transparent sheet through which you can place your glasses and then protect your face from potential viral transmission. This is just to show you how gowns can be recycled. And in my own hospital right now, we're at a shortage of gowns. And this is Mike, one of our resource nurses, who tries to humanize the experience of COVID-19 by placing his name on his forehead, because now a lot of us have hidden our ID badges so that we can prevent contamination. And then these are pictures of nurses in Mount Sinai, New York, who have used garbage bags as gowns because of the lack thereof. In the emergency room, if you have any if your patient has any pulmonary symptoms, I would strongly suggest getting a CT chest at the same time that the CTA head and neck is obtained. You're already imaging up to the aortic arch, so you might as well continue imaging a little bit further to get the chest, because you might detect these findings that are very common in COVID-19 infected patients and also asymptomatic patients. And the caveat of this is that the American College of Radiology does not recommend that CT chest be used in the diagnosis or detection of coronavirus or COVID-19. But because your patient's already in the scanner, it would seem convenient that you just image a little bit further to get this information. And just from speaking with several colleagues around town, the other way the CT chest can help is that when you're trying to rule out a patient from COVID-19 diagnosis or from clearance of precautions, then the CT chest can potentially help factor in your decision-making. Further along about the imaging aspects are what do you do in late time window? So we typically do advanced imaging to try to select patients in the late time window. And this is a recent paper that came out of the UPMC group, where they looked at the interaction between time aspects and clinical mismatch based on the Dawn criteria. What they found was really interesting. They found that patients who have high aspect scores, meaning 6 to 10, have a high proportion of a clinical core mismatch as defined by the Dawn criteria. And this high proportion of clinical core mismatch also extends out into the 6 to 12 and the 12 to 24 hours. So if your patient is already a potential thrombectomy candidate and you're thinking, do I get a CT perfusion? You can certainly add it on to your CT-CTA if it's part of your local protocol. Or if you haven't done it for whatever reason, you can think about using the aspects as a surrogate measure. And I'm sure this will be discussed later in the SBIN break. This brings the issue of the crisis standard of care. How do we think about selecting patients for endovascular therapy? So typically you can use your guidelines as always, but you also want to think about avoiding futile reperfusions and avoiding futile transfers because, again, resources are very limited. And there's also been implemented crisis standards of care for the toughest decisions when you're trying to triage the patient who you're being called about from an outside hospital. So if you look at potential comorbidities and life-limiting comorbidities, you can use some of these factors to potentially make your decision, do I make this transfer of a patient with all these comorbidities in selecting a patient for endovascular therapy in the face of limited resources, limited ICU beds, and limited ventilators. We move on to consent. So if the patient is consentable, we recommend using verbal procedural consent, especially if you're suspecting a COVID-19 patient. And the reason is because pens and tablets can be sources of inanimate viral transmission. So in this setting of the COVID-19 pandemic, it would be acceptable to use verbal consent. However, we do suggest you adhere to local standards. And also at the same time you're doing the consent, you also want to think about healthcare proxy in the event that your patient loses ability to consent. And this has implications if your patient needs to go to rehabilitation, then having that healthcare proxy can do a lot to facilitate your bottlenecks of discharge. And this is a statement that was issued by the SNAS team, Dr. Fiorella, came out last week, literally. And he says, with his team, a realistic approach to establishing do not resuscitate status for patients is discussing withdrawal of care for patients who fail to improve and demonstrate large infarct volumes on post-thrombectomy imaging is appropriate. He also says that to establish these parameters, you might talk about this at the time of initial consent. And this is obviously a very controversial area, and David Libeskind will be talking about this in about 2 hours from now, about the ethics of triage in COVID-19 crisis. Moving along, once you've gone through your consent and you're thinking about the thrombolytics or the medications you need to support your patient, you can use very long IV tubing that goes from the outside of the patient's room to the inside so that you can spare PPE usage and really tightly adjust the medications that you give to your patient, i.e. alteplase if it is, or blood pressure reducing medications or augmenting medications. This is the Optimist Trial. This is a trial that was performed before COVID-19 from Johns Hopkins, where they looked at a minimalist way to check your patient after intravenous alteplase. And how do we reduce the resources and all the checks that we do for these patients? So they looked at if patients were finished at their 1 or 2 hour checks and they didn't require any ICU related support like blood pressure lowering medications, they liberalized the criteria for monitoring their patient compared to our standard of care. And if you look at it and you break it down, you could potentially save 20 PPE visits if you adopt this protocol. And so, of course, this is going to be of interest in the setting of the COVID-19 pandemic. The outcomes from this study were also comparably very good, and patients did very well when they were selected as such. We move on to aerosol generating events. There are many events from the ER through your preparations for a thrombectomy about aerosol generating events. And this is anything from coughing, sneezing, intubation, suctioning, bronchoscopy, nebulizers, or CPR. So this is an example of what a sneeze cloud looks like. It can really blow a puff quite far and take a big distance. So you want to think about these issues, coughing and sneezing in your patient, and protect yourself from it and potentially take a step back. So this is an aerosol box that was devised by a Taiwanese anesthesiologist. And it's basically an enclosure barrier that helps protect your anesthesiologist from potential splatter. This is a mannequin that had a artificial simulation-induced cough that was labeled with fluorescent dye, and then they shone the light onto the anesthesiologist after the cough was emitted. And so you see that the anesthesiologist was splattered with fluorescent dye on his face mask, arms, and his neck. But if he had the protection device, the protection of the enclosure device, the aerosol box, the splatter was only limited to around the box and then his gloves. So this is a nod to our anesthesiologists who really need protection as they are intubating these patients, because these are highly aerosol generating events that could potentially emit viral transmission. This is a helmet devised by researchers from Michigan, where you have oxygen going into the helmet and then the patient exhales via a high efficiency particulate air filter. And this could be essentially a substitute for your negative pressure room and give your hospital more capacity to take care of these patients with COVID-19. So airway is an important issue to consider in thrombectomy. And the SBIN has come up with a couple of ideas related to this. And again, we support whatever local institutions already do. If intubation is your usual mandate and is the way you're comfortable of doing your procedure, by all means, you should just continue to do what you're used to. But when we've thought about how does COVID-19 affect our thrombectomy workflow, we've thought we should still go with conscious sedation as first line. And the reason is because you want to protect your anesthesiologist from potential exposure by a huge aerosol generating event such as intubation. However, at the same time, you want to do conscious sedation first line. You want to avoid in angio suite emergency conversion from conscious sedation to intubation. So if you're trying to select who do you intubate, the thresholds where you may lower your ideals to intubate are patients who have high oxygen requirements. So again, that's the stat you're looking at from the ER. If your patient has orthopnea, tachypnea, or they're using their accessory muscles, those you should definitely intubate. If they're agitated, uncooperative, or have active coughing or vomiting to protect their airway, those patients may be of higher interest to intubate. You also want to think about intubating in a negative pressure room, and that wouldn't be the angio suite because most angio suites are positive pressure room. So think about a negative pressure room in the ER or in your OR area or IR area. There's usually a designated negative pressure room where would you transition your patient if you are planning to intubate them. And again, these processes are not fast. Your anesthesiologist has to gown up in PPE and protect themselves, so you can't really push them to go fast. You nudge them, but it's going to take at least anywhere from an extra 15 to 30 minutes from your usual timeline. And the other question you want to ask is, do you want your anesthesiologist in the room or as needed for intubation once they're in your room, whether you're doing conscious sedation or a GA case, general anesthesia case? The Society of Neuro Anesthesia Critical Care also published their guidelines on what they thought would be adapted in the era of COVID-19 and who you would intubate or proceed with conscious sedation. And so these were the criteria they came up with, very similar to what we stated. We had some disagreements with some of these criteria. So for example, posterior circulation or dominant cerebral hemisphere occlusion. We did not think these patients should be punished and get general anesthesia off the bat just based on their neurologic presentation. High NIH stroke scale or low GCS. Again, we did not think those would necessarily mandate the patient to go to general anesthesia. We do agree with an agitated or uncooperative patient, but an aphasic patient, many of us have had experience where they tolerate just nicely to undergo a general anesthesia and potentially recover. So when you think about MAC, your patients in your room, make sure they're wearing that surgical mask. And I take a pause, I take a look and see, is my patient wearing a surgical mask before I start? Because you want to protect your nurses and your techs and your staff. And you want to avoid high flow nasal oxygen. And if they're wearing it, again, put the surgical mask over this nasal cannula. Consider putting a viral filter if you have one. And again, we talked about avoiding the urgent conversion to GA in your angio suite. As for anesthesia, we talked about the negative pressure room. The sequence would typically be rapid sequence intubation rather than bag valve mask, which is highly aerosol generating. They should have vasopressors available from the get-go so they don't have to break in and out of scrub. Think about a HEPA filter on the ET tube, and avoid any breach in the circuits. This is very important because, again, this can be a source of aerosol transmission. And then avoid the patient from coughing if possible, so you either paralyze them or give them cough suppressing medications. So in terms of room preparation, this needs time. And this is where, when I did my first COVID large vessel occlusion person under investigation case, I realized there were many steps I missed with my team. So this is why, this is what inspired us to think about this and write this all down, because there are many steps in this process that I learned from, such as you want to remove all unnecessary items in your angio suite because you don't want to have your environmental services clean up areas that you didn't touch. So for example, a lead apron that's not going to be utilized, just take them out of the room so that they don't get any exposure to COVID-19. You want to cover any countertop items with plastic or just remove them. Prepare any procedure elements you might think you need. And we started to use this box just so we have it enclosed before we do our thrombectomy. And then you want to minimize breaking in and out of the room. So think carefully what you need so that you minimize the breaking in and out. Have one tech in and one tech out. And then cover the cabinets of your supply closet before your patient comes in so that you don't have to clean all your supplies. Okay, other things as you think about moving into the procedure room, it is nice to have an observer watch you don your gown and your protective gear. It's a lot of steps, and having somebody else help you with this is very helpful. So double glove, face mask, shoes, surgical or N95 mask should really be utilized. Have some hand sanitizer near doors, and your phone and your pager, leave it in the control room. You don't necessarily want to keep this in the procedure room as I have done, because again, you don't want this to be contaminated by potential aerosol transmission. And this slide shows you the sequence of donning and doffing is quite complex. I usually have to pause and think about all the steps before I go in and out. And again, your local protocol you can certainly use, and you are welcome to use this protocol as well. This is what it looks like in our angio suite. I highlight the lead shields. I really like these, not only for radiation protection, but it is also like my aerosol box, protecting me from the patient as a barrier. So cover these. When I did my first case, it was not covered. So again, cover these, learn from my areas that I could have done better. And then my awesome technologist wearing her face mask, and us in a stroke case here. Okay, so intra-procedure, keep staff to a minimum. I'm blessed to have a wonderful technologist team, and one physician, one nurse, and one nurse, one technologist, one MD. The doors to the angio suite room, you want to tape it or put a sign so that people don't just walk inadvertently, because they often walk in and out not knowing what's going on in the room. You don't want them to walk in without their gear. If your patient is intubated, again, avoid any breach in these circuits. You want to maintain fluids euvolemic, because there's a risk of pulmonary edema with COVID-19 patients. And so this is of interest because when we're running our flushes, sometimes we don't pay attention to what's running down our heparin drips. So keeping fluids to euvolemia would be ideal. Again, avoid blood loss if you can, because we have a national shortage of blood. And you want to keep your patient with good hemoglobin levels. As you're finishing up your procedure, you want to think about discussing with your primary team what lab tests they might be interested in. So not only in stroke workup, but for COVID-19 workup, do they want to check for D-dimer, fibrinogen, CBC, whatever hasn't been done, you might want to complement that as you're finishing up your case because you're in less of a rush. And by doing this, you're potentially saving one PPE trip from your laboratory technologist. So again, we're thinking about this all for the healthcare workers who are involved in this one stroke patient, not just for ourselves, but for the whole team. It's a big team effort. And again, having an observer watch you doff is very helpful. And then trash, it's something I never think about. And make sure your trash is completely inside the trash bag so that your environmental services helper doesn't have to touch material that's outside the trash bag because it's sticking out. So one paper in China actually said to make sure that the trash is in about 75% full before closing it off. Okay, moving along, in the control room, you want to keep staff to a minimum. Some things that we don't think about necessarily is that they should wear a mask. And the reason is because, again, your angio suite is in a positive pressure room. If that door between your angio suite room and your control room opens, there's positive pressure going into your adjacent space, your control room. So anyone in the control room should definitely wear a mask. Something we don't think about, but now that we are tracing back our steps, we're learning how can we do this better. Again, you want to keep your angio door closed for these same reasons. So this is an example of my first COVID LVO. I can assure you it wasn't my fastest case from notification to getting the patient on the table. And, I said, we're not going to get any extra help. It was just going to be me and my tech and my nurse. I didn't want to invite anybody else, not even my partner. And so after one pass, the artery was nicely opened. Okay, so we're going to move on to the post-procedure checks. And this is important because it hasn't been mentioned too much in the other guidelines that I've read about. And so these transitions are important because there are so many checks after your procedure or after your reperfusion therapy. And so as you're transitioning from the patient from ER or angio suite to the ICU or the step-down unit, wherever you have your patient going, aim for one provider who is already gowned to do the check just before they leave. And so that one provider, can communicate with the receiving provider, and the receiving provider could potentially look through the glass door and examine everything with the gowned provider who's checking the access site, the vitals, the neuro exam, if they're examinable, and then hand the patient over. If you have telehealth, obviously, by all means, please use it. And then after that access site check, depending on how concerned you are about bleeding, you can check in half an hour from handoff, and then maybe every hour times 2. And obviously, if your patient is intubated and paralyzed, these frequency checks can be reduced. Or if you have a concern for bleeding, then you should augment the frequency of these checks. So kind of tailor it based on what you think is the concern for risk of bleeding and hemodynamic instability. Extubation, we all in general don't extubate in the angio suite, but especially now you don't want to extubate in the angio suite because, again, it's a positive pressure room and highly aerosol generating. So you want to find a negative pressure room to extubate your patient if your patient is COVID-19 positive. So this is a summary to show the potential workflow for the ER stroke patient. Coming through the ER, again, all of them should get a surgical mask and be screened for COVID-19. This is an extra step that we usually don't do in our stroke workflow. And if they can't speak or if they're positive for COVID, then the provider should be in max PPE. A swab should be obtained. And think about chest CT if they're already on the scanner. Now, if they've returned from the ER or if they're transferring in from another hospital, do not do a chest CT because you're losing time. So we do not advocate for doing chest CT if it takes more than an extra 5 or 10 minutes when your patient is already on the CT scanner. So please do not advertise for chest CT if they've already gone back from radiology or if they're a transfer patient. And again, the ACR does not recommend it as diagnosis. Think about these symptoms and signs to intubate or have a lower threshold to intubate. And then you're going to intubate in the negative pressure room. You do your thrombectomy, and then the patients either go to a COVID unit if they're COVID positive, neuro unit if they are not known to be COVID positive, or step down or repatriate. This is a nice quote from Dr. Leiden, who says that in the setting of the COVID-19 pandemic, full compliance of these treatment times or benchmark treatment times that we're supposed to achieve is a goal rather than expectation. And so inevitably there will be delays, easily 15, 30 minutes, 45 minutes extra from what you usually have in your workflow because of the necessity of dressing up in PPE. And we are already seeing this in our transfer patients. Somehow the transfers are longer because of the logistics of getting a patient from primary stroke center to comprehensive stroke center. Okay. So post-procedure, I find it really helpful to debrief with your team. That's how I learned a lot of the issues for my multidisciplinary helpers who help us with the patient. Delay any unnecessary tests until your patient rules out for COVID-19. For example, MRI is an important issue because the issue of decontaminating an MRI could potentially take 3 hours, as we learned from a UCLA case report that was published recently. And then diagnosis, you want to have definitive diagnosis of COVID-19 as soon as possible, because that can determine whether or not you have a patient in PPE status versus non-PPE status as you take care of them. And family communication is so important because, as you know, there's lots of restrictions of families from coming to the hospital because of the pandemic. And so you really want to be proactive about communicating with your family. Post-acute care, something that we don't usually think about in our post-acute care of stroke is testing a non-COVID patient for COVID. And the reason is because obviously, one, nosocomial transmission is possible. And two, if a patient's going to a facility, then they really should be checked for COVID, because if they have it and they're asymptomatic, they can infect the whole nursing home. And, you know, we've all seen the tragic reports of nursing homes that have been decimated by COVID-19, which will take out, you know, a whole facility with merciless precision. If we don't test, we don't know what the scope of this disease is. We're only at the tip of the iceberg. So again, that's why many administrators, politicians are advocating to test so that we can detect who's infected and who's not. Okay, Dbt prophylaxis is another important area to think about. And the reason is because there's a very common hypercoagulability that comes with COVID-19. We see DVTs or PEs in 20 to 30% of these patients who present with COVID-19. And this is a nice summary from one of our hematologists, Dr. Sloan, who looks at what do academic medical centers do with their anticoagulation protocols. And as you see, it's all over the place. Suffice it to say that it has been an important enough of an issue that many academic centers have looked at how we think about anticoagulation in COVID-19 population. And this deserves a separate topic for stroke, because obviously you have to think about your patient's degree of infarct before you anticoagulate aggressively. I'd like to highlight the disparities of COVID-19. This is a map of Boston, and the areas in dark purple are the areas that have been afflicted with higher rates of COVID-19. And my hospital lies at the intersect of all these regions. And what we've learned is that COVID-19 is really a disease of the socially vulnerable. So patients who are not able to socially isolate themselves are more afflicted than others. And you know, at Boston Medical Center, my hospital, we've treated more than 600 COVID-19 patients. And right now we have about maybe 200 patients with COVID-19, and a quarter of them are in the ICU. So it has created a big strain on our hospital resources, on our healthcare resources. And so we have to highlight the social inequities of this disease. And if anything, it can bring out more resources for this vulnerable population. Repatriation is an idea that I've become very interested in, because as my hospital got full, we had to think about how do we make openings for our patients. This is a nice paper that came out of the Dublin group just potentially, I think, 1 or 2 weeks ago. And I don't think they were planning it in the setting of COVID-19, but I looked at it, and basically in Dublin, where resources are scarce, they have patients go from the primary stroke center to the comprehensive stroke center. And then after a period of observance, that patient goes back to the primary stroke center. And these patients have had as good outcome as any other series. And so that is certainly an idea that one can think about if a system is exhausted or overwhelmed by the shortage of critical care beds. We need to think about psychiatry. And this is a study that was done in JAMA, where they looked at patients, mental health outcomes for healthcare workers who were exposed to COVID-19 in China. And they found a high rate of depression, anxiety, insomnia, and distress in these frontline healthcare workers. And unfortunately, we learned recently of 2 healthcare workers, one ER physician in New York, one paramedic also in New York who had self-inflicted wounds and unfortunately passed away from COVID-19. Again, this is a disease that takes a toll on many healthcare workers, and so we do salute you. As you're going into your procedures, you're doing a lot of videoing with your family. And next slide. I wanted to highlight the word crisis in Chinese is Wei Ji. Apologies if I mispronounced. And it's made of two components, danger and opportunity or challenge. And so we see this as a dangerous crisis. We cannot see our enemy, but any opportunity or any detail we can use to recalibrate our acute stroke workflow can potentially improve the outcomes for our healthcare workers and our patients. This is the paper that just came out as of, I think, an hour ago. And so we encourage you to look up if you'd like to read more about what we described today. A lot of great neurology friends and friends from neurocritical care helped us put this together and think about how do we optimize our workflow in the setting of COVID-19, which has really taken a radical shift. And with that, I'd like to thank you for listening. And I know together we can really crush this curve as opposed to just flatten it. You'd rather be isolated than intubated. Okay, I yield back.
Okay, so we have a few questions. Great presentation, Tom. Thank you very much. First question, do you or would you screen all acute stroke patients with large vessel occlusion for COVID if no respiratory symptoms or fever?
I would actually, because again, if your patient's going to go to a stroke unit and they have COVID-19, they can infect that whole unit. Or if they go to a post-acute care facility, then again, they can infect that facility, and that's really bad. So I think we should screen them all. And the question is, when? Do you screen them on presentation? I think so. And do you screen them before they leave? For sure. But how soon from when they leave should you screen them? Like a day or a few days? I don't know the answer to that. But that's something to be discussed with your case manager and the facility that's accepting your patient.
Okay, can you comment on any changes in the timing of post-thrombectomy thrombolysis imaging to minimize repeat imaging and get the optimal imaging information? For example, if we need to restart anticoagulation, how long should we wait? Some institutions don't have that 45-minute test or even a one-day test. We're still waiting on some results like 3-4 days at least. So what would you recommend?
Great question. So CT scan rooms are pretty well attuned to taking patients with COVID-19. So if you screen with a CT scan, I think that should be enough information to figure out, if their patient has hemorrhagic transformation of their stroke, so you can restart their aspirin or restart their anticoagulation if they have a small burden of stroke. But I think CT scan is completely reasonable. If you can wait a few extra hours or one day, then wait. But otherwise, if you don't think you can wait, you're trying to meet the guidelines, I have to get my aspirin within 24 hours, then you might nudge your CT scan a little bit earlier to get the scanning done.
Do you have a dedicated scanner?
Yes, so there's a paper from radiology where they looked at emergency preparedness for radiologists and for radiology departments. And so most hospitals at this point have dedicated COVID-19 CT scans. And if you have multiple angio suites, then you've probably already made a dedicated angio suite for COVID-19. Amir, have you had a dedicated angio suite for this?
Yes, we have one of our rooms, one of our biplanes dedicated for all acute cases, subarachnoid, acute ischemic stroke that come up. And we do screen everybody as if they're potential COVID. And thankfully, it's been pretty good. But yes, after having a partner go down, I needed to make sure that nobody else went down.
Absolutely. And not only that, but sometimes we think about doing our strokes in the monoplane room because there's probably a designated, COVID monoplane room. And so we think, okay, instead of using up my one biplane, I might just do my stroke in the monoplane room.
So there's a thank you. And then is there value during the telestroke consult when considering transfers to hubs for mechanical thrombectomy to ask the spoke to obtain the COVID testing? For patients, COVID mimic possible exposure prior to transfer. What do you think about that?
I think if it doesn't delay transfer, then you're already getting ahead, and you kind of want to know how long it takes to get the test back. So if that facility has good turnaround time, by all means, and then you obviously maintain communication. But a lot gets dropped in translation from the primary stroke center to the comprehensive stroke center, meaning a lot of times, honestly, in reality, the CSC team, they don't look at the stuff that's going on from the PSC area. That's probably your experience too. So I think just in terms of efficiency, really think about don't delay the primary stroke center from transferring your patient, because they have a lot to do as it is, and just deal with the tests at the comprehensive stroke center.
But if they had the rapid test, yes, I would agree, but none of my spokes unfortunately have it. What is the average delay in time for thrombectomy at your center when a patient needs to be intubated for being a suspected COVID patient?
So we've been doing mostly conscious sedation for our strokes. And if it's going to be intubated, I mean, I can tell you the experience of a subarachnoid hemorrhage patient was easily, up to an hour. But again, that's a subarachnoid. It doesn't have the same pressing urgency as a LVO. But the anesthesiologist, I feel awkward about pushing them, gotta go fast, because I see them, putting themselves at major risk from an aerosol generating event. So I guess that's a good question to ask you back is, how do you talk to your anesthesiologist about, okay, we need to move forward, but we want you to protect. So it's an interesting conversation.
No, and it definitely is. So in our institution, we're like you, very much like to do all of our cases awake, but we did lower our threshold for intubation a bit. So for the handful of patients that were intubated, honestly, they did a very good job. I would say it didn't delay more than 15 minutes. Most of our ED team, everything that goes into the trauma stroke base, they're already considering a potential COVID. So since the same nurse is wearing, everything head to toe, you're saving PPE because they don't have to keep changing in and out of it. They're doing a pretty good job on that. But in general, I would say between intubation and then you doing the appropriate things, because remember, if we don't intubate, then we're doing the donning, the doffing, we're delaying at least 15, 20 minutes on our end, getting ready for the case and making sure everybody's safe. So if you intubate, close the circuit, I actually think it's almost the same amount of time.
Yeah, and then transporting from the ER or wherever you are, the ICU to the angio suite, is also another affair, because you have to think, okay, am I going to disconnect the ventilator and bag valve mask while they come, or do I bring the ventilator along with me to the angio suite? So it's a big transition. All these transitions, wherever you send your patient, on how do you transport them. And in one of the papers in China about workflow for cardiovascular interventions, they say they map out the transport routes, and they map out which elevator that they transport these patients in. I'm digressing a little bit, so I'll get back to your questions. But it's so interesting, like how the workflows have changed in the setting of COVID-19.
So we still have some time, so we have some good questions here. Some of them I'm answering. So for those of you watching, I can answer it. If she already answered it in the presentation, I'm actually typing in the answer so she doesn't have to repeat herself. So is there a need for anticoagulation in COVID patients with large vessel strokes post-thrombectomy?
Great question. I think at this point, you should just treat them as you already do and not necessarily escalate. But for the Dbt prophylaxis, I think you should be more aggressive and look at what your institution protocols are. Because again, these patients are high risk. If your patient is bedbound, moribund, you're balancing the risk of hemorrhagic transformation of an aggressive anticoagulation protocol, which most of us are not used to, versus the risk of more thrombotic events. So I don't think we have all the answers for this, but if your patient has a small burden of infarct and they're already expressing, high D-dimers or high chances of coagulopathy, you might be more aggressive on those patients. But otherwise, I think we don't have a great answer to anticoagulating for stroke. But I think at this time, I would just go with what you already do and be a bit more aggressive on the Dbt prophylaxis.
Okay. This is a great question. Rosmic is asking, are institutions adding CT chest to code stroke imaging protocol? And I know that we had this conversation when you were writing the paper, so.
Yeah, so they're doing it in Egypt. That's where we first heard of the idea from one of our colleagues, Dr. Mansour. There are places around the country that are already doing it. But again, anything that is a change in the workflow, it takes a lot to embed it into the workflow to change all the protocols. We haven't adopted it at Boston Medical, but slowly, I think if this idea popularizes, we may adopt it.
Okay, there's some anecdotal reports on false negative testing and positive serology testing later. In such scenarios, how would you approach?
I think the idea is to assume everybody has COVID. I think that's the easiest thing. You know, when I round on my patients, and again, I'm minimizing rounding because of COVID and PPE, is just to keep your 6-foot distance, wear a mask, and I don't do a lot of human contact with them. You know, I don't do my sensory exam like I should. I ask the patient to touch themselves to check the sensory exam, and I really limit human contact. So negative tests don't reassure that the patient is truly negative. And so I think it's up to your ID team and your local criteria on how you rule out COVID-19 that you would adhere to before you really lift off the restrictions. But again, even if they're negative, I think we should all take precautions, because what if the provider has COVID? You know, like what if I have asymptomatic COVID I don't know about? I should still keep my distance from my patients. And again, I keep my distance from my family anytime I come home from the hospital. I don't know if I just got COVID. But I would just still enforce social distancing, even with your patients, even if they're COVID-19, because again, you don't want to give them COVID if you have it.
So is there any value in chasing D-dimer and fibrinogen post-thrombectomy? Would you?
Great question. It's so that's not standard in our current stroke workflow, right? But there's a lot of literature that's popping up about serial D-dimers in patients who have severe COVID on ventilators. So those patients I would, because again, if they're hypercoagulable, just increasing the coagulopathy without treatment will make them worse, because they go into multi-organ failure as they clot off the microcirculation for every organ. So yes, D-dimer is associated with higher mortality. We're learning that, and anticoagulation may help. However, in a stroke patient, you really got to be careful, because if they have a huge infarct, that will be your rate limiting factor. Because again, these patients can blow pupils and they can hemorrhage into their infarct. So I think you need to exert caution on the patients who are at risk for huge hemorrhagic transformation.
Okay. So there is a rising data about COVID-related stroke in young patients with no risk factors, with false negative possibility of the testing. So would you keep these patients as COVID rule out and repeat testing multiple times before you would say no COVID? If you get a young stroke, would you continue to test?
I think there are centers that are testing multiple times. So I hear about, 3 times being tested to really make sure. But of course, we all see young patients with no risk factors and cryptogenic or embolic source of unknown source. And so just because COVID exists doesn't mean everything is COVID. So I think we need to separate, yes, true, but potentially unrelated. And then again, keep all our precautions. And if the test is negative after 3 times, I mean, what are we chasing here?
Yes, no, I completely agree. I think, unfortunately, we do have a lot of young strokes on average. We'll get to 30 and 40-year-olds, but they're hypertensive, diabetic, obese. So yes, I'm not going to be thinking COVID. But yes, if a runner came in and she's completely healthy and asymptomatic, I would probably repeat testing.
I mean, if you look at the Chinese data and the Italians and most of the Northeast other than New York, we're not really seeing this surge of ischemic stroke. Right? I mean, most places are expressing that the volume is lower for their minor strokes, their TIAs and the stroke admissions. And a lot of that driven by the fear of families and patients have of coming in and contracting COVID. So we're not seeing this necessarily, other than potentially the geographic areas of New York City and Philadelphia.
Okay. So how did your material management people in Cath Lab, help with COVID-19? What are they doing? What limitations do you have? Do you have like a marked area for donning and doffing?
Yeah, so on my first COVID patient that I showed you, there was actually an educator. Thank goodness it was during daylight hours. An educator just came in, and I never met her. I didn't know who she was, but she was watching and she was helping me don and doff. So I had that luxury of an educator from the OR come into our IR suite because they knew it was a COVID rule out coming in. And then we do have an area that's marked with red tape. That's 6 feet from the patient's bed in the angio suite that would mark where you would doff your room, because most of us don't have the luxury of what they call the ante-room, or the room where you would don and doff off. So definitely, if you don't have the luxury of the educator, I would ask you just to ask your partner or your nurse or your tech just to help you think about all the steps through, because again, it's not intuitive. I've done the whole diagram, but I still have to pause and think about it. So it always helps. And again, in that protected code stroke that Dr. Kasravani wrote about, he wrote that you want to have a buddy who's your safety officer. So anyone you designate as your safety officer to watch you do your PPE properly, because you have blind spots. You have spots you can't see that should be covered, and that person can really help you make sure you do it right. So that gives you the confidence that you're appropriately donned, and then the confidence that you will not contract as you meet your patient.
Okay, thank you. So have you seen any outcome changes for patients who had COVID positive stroke and placed on anti-interleukin-6?
No.
No, neither have I.
Thanks for the question.
How are you implementing telehealth into your stroke workflow in your comprehensive center as well as your primaries?
So that's a great question. In fact, it's going to be addressed by our next speaker. So I don't want to steal their thunder, but suffice to say, we've gone very heavy on telehealth for outpatient practice and converted all our outpatient follow-ups for our patients from the hospital to telehealth. And so that has really been the main driver. The technology of telehealth really hasn't been in our hospital other than iPads. They have iPads that allow you to check on a patient, or baby monitors. If you don't have the fancy equipment, you can use baby monitors as a potential way to monitor your patient for telehealth.
Okay. So for D-dimer and ferritin are monitorized close to many centers here in Spain for a few weeks now. They don't have a lot of data yet. They seem to be happy about it, but no in-hospital strokes at their center. But they've had a low COVID rate. I think this was just, okay, thank you very much for that. Are you screening all COVID patients for APS?
Oh, antiphospholipid. There was that one article in the New England Journal. I haven't been pursuing it aggressively, and that's in part because of the APAS trial, which was a sub-study of the WAR study, which didn't show any significant benefit if you had your patient with antiphospholipid syndrome and they were randomized either to aspirin versus anticoagulation. So because I don't even change my practice necessarily when I have a antiphospholipid antibody positive from the get-go because of the APAS trial in my regular practice, I haven't necessarily been adopting it for COVID-19. This is all speculative. I'm not saying it shouldn't be done, but of course, if you feel compelled and you have all the resources, by all means, it's an academic question. It's interesting, and explore it.
And let's see here, maybe one last question. Excellent talk. Have you had any evidence or experience that post-thrombectomy asymptomatic COVID patient who was intubated prior to procedure then deteriorated due to COVID and not due to the stroke?
It's a loaded question. Can you repeat that? Asymptomatic COVID patient gets intubated and then?
And then worsened due to COVID, not due to the stroke.
Oh, I mean, it's bound to happen. I haven't had that specific patient as described.
Yes, I mean, I know the Joanna Fifi and company have pretty high volumes of COVID positive elbows, but overall, we're discussing with several high volume centers over the last 48 hours. It's not as high as we expected, right? We expected to have a lot more elbows with COVID positive, and that doesn't seem to be the case. So to find an answer, to ask that type of question, you'd need hundreds of patients. So thank you very much, Tom.
Thank you, Amir. Thank you, everybody.